Welcome to the ASCO eLearning Weekly Podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complimentary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Hello, my name is Dr. Tarita Thomas, an Associate Professor of Radiation Oncology at Loyola University Medical Center in Chicago. Today, we compare two patient cases on breast cancer axillary management of nodal disease in the neoadjuvant era. Less is more or less the same. The role of adjuvant radiotherapy in management of nodal disease. I will present two cases that have similarities, yet the recommended treatments may be different. Let's look at the cases. Case 1 is a 45-year-old African-American female, Kendra, who was found to have a clinical T2 4.7 centimeter tumor, N1 with the largest node measuring 2.9 centimeters, invasive ductal carcinoma, grade 3, ER negative, PR negative, HER2 negative, or triple negative, Ki67 unfavorable 60%. She had neoadjuvant chemotherapy with 4 cycles of dose-dense AC, followed by 3 cycles of paclitaxel. She underwent bilateral mastectomy, left sentinel lymph node biopsy with 6 sentinel lymph nodes removed, and bilateral expander placement. Pathology from surgery showed no evidence of residual disease. She was a YPT0, N0, M0. The second case is a 64-year-old Caucasian female, Martha, who was found to have a clinical T2 3.5 centimeter tumor, N1 with the largest node measuring 3.6 centimeters, invasive ductal carcinoma, grade 3, ER positive, PR positive, HER2 negative, Ki67 greater than 15% unfavorable. She also received neoadjuvant chemotherapy, 4 cycles of dose-dense AC, followed by 4 cycles of paclitaxel. She had left skin-sparing mastectomy and sentinel lymph node biopsy, with immediate placement of silicone-filled breast implant. Pathology from surgery showed no evidence of disease, YPT0N0. As you can see, both cases are very similar, but there are some differences. Would the differences lead your choice of treatment in a different direction, or would both patients receive the same treatment? In terms of background for this case, I'd first like to address the question of who is a candidate for neoadjuvant chemotherapy or neoadjuvant hormonal therapy. These include patients with any operable, locally advanced, or technically inoperable invasive breast cancer, clearly indicated in inflammatory or technically inoperable breast cancer, clearly indicated in patients desiring breast conservation, but would result in suboptimal cosmetic results without downstaging prior to surgery. Neoadjuvant therapy is optional in early stage of disease based on physician, patient, and institutional preferences and biases. Neoadjuvant chemotherapy is the ideal setting to evaluate novel biomarkers as early indicators of response to chemotherapy, such as in the I-SPY 2 trial. This trial compares the efficacy of novel drugs in combination with standard chemotherapy with the efficacy of standard therapy alone. The goal is to identify improved treatment regimens for subsets of patients on the basis of molecular characteristics of their disease. Available data suggests equivalent overall survival, disease-free survival as adjuvant therapy stage for stage, with substantial response rates, downstaging, and conversion from inoperable to operable, and increased success for breast conservation if desired. There are clinical trials that have evaluated the role of neoadjuvant chemotherapy and have helped to identify patient populations who may not need radiation therapy. NSABP B18 is a phase 3 randomized trial of operable patients, T1 to T3, N0 to N1, who received preoperative AC versus postoperative AC. There were 12% more lumpectomies performed in the preoperative arm, equivalent overall survival, with a pathologic response that was complete of 26%, with only 11% having DCIS. NSABP B27 was another neoadjuvant chemotherapy trial of 783 patients randomized to AC plus a taxane followed by surgery, or compared to 777 patients randomized to AC followed by surgery and then a taxane. Addition of taxane significantly increased the complete pathologic response, 26% versus 13%. As with B18, those who achieved a complete pathologic response had superior disease-free survival and overall survival, compared to those who achieved less than a complete pathologic response. Local regional recurrence among patients in NSABP B18 and B27 who received neoadjuvant chemotherapy, mastectomy, and no post-mastectomy radiation were stratified by pathological extent of response in the breast and lymph nodes at the time of resection. Response to chemotherapy was a strong prognostic factor in risk of recurrence. 10-year risk of recurrence for those who had clinical node-positive disease, who had a path CR in the nodes and in the breast, had a 0% risk of local recurrence, versus those who had a YPN0 but did not have a path CR in the breast. Risk of local recurrence was 8.1% in the post-mastectomy setting. In addition to B18 and B27, B32 was another NSABP trial of 5,611 patients with clinical node-negative invasive breast cancer who were stratified to sentinel lymph node biopsy and axillary node dissection, or sentinel lymph node biopsy and axillary lymph node dissection only if node positive. 8-year overall survival was non-significant, disease-free survival was non-significant between the arms, and regional nodal recurrence was non-significant. For all these trials, the critical point was there was no post-mastectomy radiation allowed. For residual node-positive disease after neoadjuvant chemotherapy in these groups of patients with operable breast cancer, the 8-year risk of local regional relapse was greater than 15%, suggesting that the need for post-mastectomy RT in patients with residual node-positive disease. For those with residual node-negative disease, the risk of local regional relapse was less than 10%, suggesting post-mastectomy RT may be eliminated in those patients with a complete response. However, there is other data suggesting a continued role of post-neoadjuvant RT in the setting of mastectomy or breast conservation. A meta-analysis of 3,481 patients from the GAPAR trials looked at the relationship of omission of adjuvant radiation to outcomes of local control and disease-free survival in patients with or without a path CR after neoadjuvant chemo. The overall risk of local regional recurrence was 8.3% with a median follow-up of 55.9 months. The absolute advantage of RT regarding both local recurrence-free survival and disease-free survival was highest among patients with clinically positive lymph nodes at first diagnosis. Hazard ratio 2.3 with a p-value of 0.001. In patients with a path CR, the 5-year local recurrence-free survival was 95.7% with RT versus 86.6% without RT. P equals 0.051. 5-year disease-free survival, 86.9% versus 56.1%, P less than 0.001. In patients without a path CR, the local recurrence-free survival was 88.6% with RT versus 80.7% without RT. And 5-year disease-free survival was 72% versus 65%, both significant. Multivariate analysis with adjustment for baseline parameters as well as for pathologic tumor stage and path CR confirmed RT as independent prognostic factor for local recurrence-free survival, P equals 0.004, and disease-free survival, also significant. In addition, there is some retrospective data from Wright et al. In Cancer 2012 looking at predictors of local regional recurrence with neoadjuvant chemotherapy and post-mastectomy radiation therapy. These authors reviewed 464 patients who received neoadjuvant chemotherapy, mastectomy, and post-mastectomy radiation. Follow-up of 50 months, 5-year risk of local regional recurrence was 6%. Predictors of higher risk of recurrence include presenting stage, receptor status, ER negative or triple negative, pathologic response to neoadjuvant therapy as well. Going back to our cases, these two cases are related in that both patients had locally advanced breast cancer with nodal involvement and pursued neoadjuvant chemotherapy, and both had a complete response to therapy. The studies discussed today suggest that neoadjuvant therapy results in high clinical response rates and respectable complete pathological response rates, with complete pathological response correlating with better disease-free and overall survival rates. Neoadjuvant therapy will result in significant downstaging to allow increased utilization of breast conservation in patients desiring breast conservation. Overall, survival and disease-free survival rates appear to be the same as patients treated with similar systemic therapy given adjuvantly. Clear indications for post-mastectomy radiation following neoadjuvant therapy and mastectomy include the majority of patients receiving neoadjuvant therapy and mastectomy, with absolute indications including locally advanced T4 disease, clinical node-positive disease, inflammatory disease. It is also highly recommended in patients who have residual node-positive disease following neoadjuvant therapy. Controversial and unanswered questions regarding radiation following neoadjuvant therapy include those patients with a complete response or who convert from node-positive to node-negative following neoadjuvant therapy. The current clinical trial, NRG B51, will hopefully address this question. This trial is for patients with clinical T1 to T3 N1 disease with documented nodal involvement by FNA or core biopsy who receive neoadjuvant chemotherapy and have definitive surgery with histological documentation of negative axillary lymph node disease. These patients are stratified based on type of RT and surgery. Patients who have lumpectomy are randomized to either whole breast RT alone or whole breast and nodal RT. Patients who have mastectomy are randomized to no chest wall radiation or chest wall and nodal radiation. Going one last time back to our cases, both patients presented with N1 disease with a path CR in the breast and the nodes. However, there are some differences. One patient had triple negative disease with retrospective data suggesting a higher risk of local regional recurrence. Currently, treatment decisions are based on the clinical stage of disease following neoadjuvant therapy. However, the ongoing trial NRG B51 will help us make more informed decisions about nodal radiation in the future. Both patients were offered participation in B51. Kendra with a triple negative tumor decided not to participate in the trial and received post-mastectomy RT to the chest wall and nodal regions. Martha with the ER/PR positive HER2 negative tumor participated in the trial and was randomized to no RT. Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. For more information on the adjuvant treatment of breast cancer, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive eLearning Center at elearning.asco.org.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.